As I previously mentioned, this patient represents treatable disease but not curable disease, and at some point he is going to progress. Hopefully, when you're followed closely, that the disease progression is detected when the patient still has a good performance status. In the second line setting, and I clearly think there is value to second line setting, the current standard of care is the use of one of the immunotherapy drugs. We have data with nivolumab, pembrolizumab, and atezolizumab, all compared to the old standard of docetaxel. And all three of those drugs easily beat the old standard docetaxel. So over the past couple of years, the second line standard has changed from docetaxel to use of one of these immunotherapy agents in the second line setting. If the patient had, and this patient does not, but say the patient had a contraindication, some autoimmune disease that they couldn't get immunotherapy from a safety point of view, then I think that I typically in that setting use the combination of docetaxel plus ramucirumab. And that's a phase 3 tested regimen. Docetaxel versus docetaxel plus ramucirumab, superior response, PFS, and overall survival rate. So that's my go-to regimen. And I would use that in the third line setting following immunotherapy if the patient were eligible to get immunotherapy. So I use it either second or third line. But I think right now, the best second line option for these patients who have no contraindications to immunotherapy is use of either one of the PD-1 drugs, Nivo or Pembro, or the only PD-L1 agent, atezolizumab, in this particular setting. We could talk, and you might get different opinions about which one is best in that setting. The reality is that they all look very similar with regard to both efficacy and toxicity in this setting. So I think that it's nice to have choices, and we're in a land of plenty in this area with regard to options for these patients, but that's the standard in the second line.